Thank you, Mr. Chairman. And thank all of you for your patience today. I hope we gave you some nice water and a few things to keep you from starving to death while you've seen our lifestyle. There is no control. I mean, the last 3 days I've had one started at 3:45 in the morning, finished at 10 at night, you know. But anyway, thank you. I'm really thrilled. I think you all know that I have somebody from a home on the panel, and a very special woman who grew up in Huntington, West Virginia, which is where I'm from and she's from. She was schooled there, went to the university, to the medical school, and practiced in West Virginia for such a long time. And she's been a tireless advocate for the people in West Virginia. But it isn't just, I mean, those same people are in Missouri, they're in upstate New York, they're in Tennessee, we're rural. And so her life has been so interesting doing that, as well as PEIA, which is West Virginia's Public Employees Insurance Agency. She stepped into that as director for quite a while. So she served as the chief medical officer at the state's second largest federally qualified health center. And in that role, she oversaw clinics across the central part of our state. Our state is so mountainous, it is so rural. And I have worked endlessly on rural health care because it can take you 5 hours to get to the hospital. If that's where your physician is, and our roads are like this, and if you were a crow, you could fly over it, but you can't. So it's quite a practice. I mean, quite a problem sometimes for people to get where they need to be. So as I said, I've dedicated my time here and on the Health Committee to help rural West Virginians and rural patients all over the country. And people who live in urban areas don't really comprehend the difference. Unfortunately, with Medicare's value-based care models, we have now seen multiple instances of the rural providers being left behind and unable to participate. According to 2021 report from the Government Accountability Office, rural providers participate in value-based care programs at lower rates than non-rural providers. Now, I don't know if you've covered any of this because I haven't been with you for the last 3 hours. But Dr. Chenard, in your opinion, what are some of the primary factors preventing our rural physicians from participating in value-based payment systems?
Administrative burden comes to the top of the pile. When you're in small practices, it becomes very difficult to dedicate a team to be able to, first of all, understand what the opportunity is, and then the tracking that goes along with it, the reporting that has to go along with it. So I think one of the reasons, at Main Street, what we're trying to do is take some of that burden off so that rural clinicians have a better glide path to participate. So there are other aggregators. Primary care associations are another great stopping place for people to find information and to really be able to figure out how to participate. I think on top of that, we're just so busy. The demand for care is so high that in order to make that change, there are a lot of technology tools that we need to use, other things that just feel like there's sort of this sentiment of throwing up your hands that it becomes too difficult. So the reason that I took my job at Main Street, it was a tough decision to leave patient care and do something like this. It is because I think that if I can create this impact by making sure that not only by giving this health navigator to practices who help take some of the daily administrative burden off of clinicians, but then also be able to support them in ways that they can stay in place. One of my fears is that we lose rural clinicians because it's just too darn hard. So if we can support them in those ways, I think that's really the most important thing we can be thinking about right now.
And once you've met those people in the area, as a physician, you become so engaged with them. It's a different thing. One particular example of value-based care model that failed to adequately consider rural providers was the CMMI's Emergency Triage, Treat, and Transport, or ET3 model. The ET3 model was launched as a voluntary 5-year payment model to provide greater flexibility for EMS providers following a 911 call. And those providers, including those in the state of West Virginia, were thrilled to have a chance to treat certain conditions at the scene of a 911 call, or to transport patients to alternative sites of care outside of the typical emergency room transport. And many rural providers were discouraged, however, when they learned that CMMI did not adequately consider that not all rural communities have an alternate site of care within their model regions, which made them unable to participate in the model. So I, with a lot of other West Virginians, sent a letter to the CMS administrator last year highlighting these issues and asking for the agency to consider allowing West Virginia to advance a statewide demonstration of a treat-and-place model, since the state wasn't able to participate in ET3 model. Not only did CMS deny the state's request, but unfortunately, they then decided to end the ET3 model 2 years early rather than remedy the issues that prevented EMS providers from participating in the first place. Dr. Chenard, I'm sure you're familiar with these issues, particularly from your time with PEIA, but in your opinion, how can CMMI do a better job of integrating small, rural, and independent providers into models? And what factors of rural care delivery does CMS not seem to adequately consider when creating these models?
One of the things I think is problematic are volume thresholds. In the example that you gave, I think there were, I can't remember the exact numbers, but you had to have X number of transports in order to participate. Well, the only county in West Virginia who met that threshold was Kanawha County.
Big one.
Right. And so having served in rural emergency room, lots of patients come in who did not need to be in the emergency room.
Yes.
But again, by law, there was really no choice. I think the other thing that contributes to a model like that is social isolation and loneliness. Lots of patients who are anxious and lonely end up calling EMS, as a result, think they have a heart attack and get transferred. By thinking about programs that would engage rural seniors, to be able to have rural seniors have extra support, we mentioned these phone calls in between visits, checking on patients, making sure that we're getting ahead of things in the vein of prevention, ensuring that if a congestive heart failure patient is, their ankles are swollen or they're short of breath, that we're getting ahead of that and bringing them into the office. So I do think that your suggestion that we think about the unique scenarios, problems, the geographic distance, and just the volume of people in rural communities should be a thrust of design principles in future models.
Thank you so much. I yield back.